Right, Introduction to Psychiatric Nursing Part 1 by Jack Wheeler. Okay, why do all registered nurses have to take psychiatric nursing? The simple answer to that is because psychiatric patients, they have more than the regular medical concerns, so they show up at the ER a lot, they go to their doctor more often, they also have babies, they have problems when they're young, so they go to pediatric units. And also, all patients have a psychiatric component to them, even if they don't have a psychiatric disorder. So psychiatric nursing is important for everyone to know because it's in all the different specialties. What happens on a locked psychiatric unit? It's similar to a regular unit in that the meds are given, 9 a.m. are basically the morning meds, then there's 1 o'clock meds, 5 o'clock meds, then 9 p.m. or bedtime meds. And so it's similar that way. It's different in that the patients aren't stuck in their room. They're not bed bound. And you'll also notice that there's not a lot of belongings and things in the rooms. And that's another reason they're not bed bound. And, we don't encourage them to stay in their room. We want them to be out going to groups and socializing with the other patients. And then there's the fact that having a lot of things in the room would create safety problems. Like, we have to worry about things that they could hurt themselves with. So there's not going to be a lot that you see in their rooms. So how does the psychiatric unit help people? Um, there's basically two different categories of people going to the psychiatric hospital. It's a little bit of an overgeneralization, but there's people that have a serious psychiatric issue, like maybe bipolar disorder or depression or maybe even schizophrenia or schizoaffective disorder, some serious psychiatric condition that they have to manage. And they can usually do so mostly as an outpatient when we get them stabilized on meds and kind of hooked up with outpatient treatment professionals like psychiatrists and caseworkers. And then there's other people that don't have a serious psychiatric condition, but they're going through something really stressful in their life. They're going through a divorce, they're going through the loss of a house, or, whatever goes on in people's life, trouble in school, those kind of things. And so psychiatric hospitalization, it helps. Our main goal is to get people back to their baseline. We're not trying to help them self-actualize, which is a theory we'll talk about in a few minutes. We're just trying to get them back to their regular, normal baseline level of functioning. And so we're trying to stabilize the people that have a psychiatric condition and the people going through a life crisis. Why do people sometimes require psychiatric hospitalization? Just like I said on the previous slide, two basic things. They'll either have a psychiatric condition that they're managing and they've decompensated for some reason, or they're a person going through a life crisis. And the way it helps, just to go back to the previous slide a little bit, the way a psychiatric hospital helps is just by providing a structure, going to bed at the same time, getting up, and then having meals that are ready, getting your meds on time, um, having someone to process it with you when you're having a problem. There's always somebody available to talk, um, even if it's just a mental health worker or a certified nursing assistant. It doesn't have to be a big professional, but there's always someone around. And so that's very helpful. Um, all right. Am I going to be in danger? It's it's rare for psychiatric patients to target nursing students because nursing students aren't the one that are telling them that they have to stay in the hospital. Generally, they're not the ones setting limits when patients are acting out. That's, the regular staff takes care of that. And so generally, psychiatric patients, they generally like the nursing student. Sometimes the nursing student, they're the only person that really has time to spend a lot of time to talk to them. And so they can be, sometimes, especially if it's a patient that likes to talk a lot, the regular staff might not have enough time, and they also might be tired of hearing the patient's story, to be honest. And so nursing students are generally not the focus of a patient's aggression. They sometimes can be the focus of a patient that has a sexual preoccupation, something like that. If that happens, that's something you definitely want to tell the staff and tell your teacher. Um, every once in a while, there has been a student recently that was punched by a little old lady on the Psych unit at Herrick when they were taking her out of, getting her up from bed when she didn't want to get up. And this lady hit my student in the ribs, but the student was okay. It wasn't a great experience, and it's never okay to be assaulted, but, it wasn't the end of the world. The student was not injured. Um, but I don't expect that to happen. And, if it does, we'll manage it. But one of my priorities is that that you learn and you're safe. So your safety is really my top priority. I have in the past, when units are really dangerous, I have just taken my students off the unit because, it's important to me that you are safe. But to answer the question, are you going to be in danger during your psychiatric rotation? It is very possible. Um, Despite everything that we do to keep you safe, it is an unpredictable type of environment. And so it is possible you'll be in danger, but we'll do everything to keep you safe that we possibly can. All right, so some basic concepts of mental health and mental illness. Generally, things are culturally defined. So what is normal in one culture could be unusual or odd in another culture. And so you have to always look through things through a person's culture. So one of the formal definitions you'll see here, the successful adaptation to stressors from internal or external environment. What they mean by internal environment is your own, sometimes your own negative thoughts. We'll talk about cognitive therapy toward the end of this lecture. And also, if if you're having a psychotic episode, you could be hearing voices. So that's other things from your internal environment. And then external is like things that happen to you in your life, like, divorces, job loss, trouble in school, whatever. And your ability to adapt to those kind of stressors. Freud has a more simplistic definition of psychiatric health, and what he says is the ability to love and to work. What he means by that, by the ability to love, he means if you can have relationships that are fulfilling, and then by work, he means if you're able to be a productive member of society, then basically, no matter how odd you are or you know weird your behaviors might seem to other people, if you're able to love and to work, to have relationships and to hold down a job and be a successful student, then you're basically psychologically healthy, even if you're weird, to put it in simplistic terms. All right, so other definitions of mental health. We have Abraham Maslow. He was a psychologist, and he came up with a famous theory called the hierarchy of needs, a 5-stage model that we'll look at on the next slide. So self-actualization, you can see, is the highest level. most of our patients, when they come into the psychiatric hospital, they're either at the very bottom here, physiological needs or safety needs. And, they could be homeless, they could be suicidal, they could be doing things that are where they're not intentionally suicidal, but they're putting their life in danger by their behaviors. And so that's one way of looking at it here. So Abraham Maslow, hierarchy of needs, and self-actualization. It's one of those things that's a goal that most people don't reach, but it's something to strive for. And then a formal definition of mental illness is basically maladaptive responses to stressors. So you have your stressors coming from either internal or external to you, and then and your reactions to them, all your thoughts, feelings, behaviors, they don't match the cultural norms, and they don't help you. They interfere with your ability to, like what Freud would have said, to love and to work. So social your social experiences are interfered with, your job, your occupation, and even your physical health are interfered with. And so, we can see that with some of our patients, their physical health, when they're, because of their psychiatric illness, they're homeless or something like that. And so Horowitz describes it as when you have somebody that's doing a lot of behaviors that really, when you look at them, you can't figure out any possible reason why they would be doing those, that they're totally incomprehensible to most people that are normal in that culture. And then cultural relativity, that that it's outside anything that's normal in the culture. The diathesis-stress model, and I'll go over what this means. Diathesis just means the biological predisposition, and then stress, environmental stress or trauma, and when we talk about environmental stress, it's also the kind of stress we can put on our brain when we abuse substances. And then, this is the most accepted explanation for why some people can have the genetic predisposition for a psychiatric condition, but it doesn't come out. It's not expressed. Those genes aren't expressed, but in other people, they are. With our major mental illnesses, bipolar disorder and schizophrenia, what identical twin studies show is that if one of the identical twins has the psychiatric disorder, the other identical twin only has the psychiatric disorder about 50% of the time. And so that's much higher than the regular population, which is about 1% for schizophrenia. And I'm not quite sure for bipolar disorder, probably a little more than that. So 50% is a lot more. So the biological predisposition is very important, but it's not everything. It's not everything even close. It's not 100%. And so there's traumatic events, there's, whatever stress is going on, there's things going on in the family, which you would think would be similar with identical twins. They're usually from the same family, except in extraordinary cases. Substance abuse is a big thing, part of it too. Like I mentioned, those things that are very, very hard on the brain and can cause it wouldn't cause the person to get schizophrenia if they didn't have the biological predisposition or bipolar disorder, but causing that stress on the brain, if they have that genetic predisposition, can cause those genes to be expressed. Okay, and it's considered to be a combination of these two factors. So one of the things that you'll see when you read the history and physical on your patients on the psychiatric unit, just like on any other specialty, you'll see there's under the H&P, history and physical, you'll see the psychiatrist's initial diagnostic interview with the patient with their it's usually the first day that they see the patient and they've done a long interview. They'll have all the different things, the history of the presenting illness and all of everything. And you'll see part of that is what's called a mental status exam. And that will contain all the different little sections. And it's worded in a way that's trying to be as objective as possible. And it'll cover all these areas. Okay, theories of personality and psychotherapy. So personality defined as kind of a constant, the way a person is throughout their life. People do grow and change throughout their life, but there's usually a basic kind of foundation of how they think and how they act and how they are in social situations. And so we have theorists that look at a life cycle perspective, and they see that people kind of go through predictable challenges in their life. These stages, they're usually identified by age, but one of the things to remember is nobody's exactly on the same schedule in their development. And if you don't complete behaviors at a certain stage, you can correct that later on. The people will get fixated at a stage or stuck, but they can come to them later on. And so sometimes the stages overlap and they might be working on things from more than one stage at a time. But, we'll talk about how people can look at, with our main state theories that we're going to go over, about how they look when they're fixated at a stage. So our first big one is one of the most famous people in history, Sigmund Freud, who came up with psychoanalytic theory and a form of therapy, talk therapy, along with it. Freud is widely thought of as the person that kind of pioneered the idea of therapy, of talking to a person, also known as the talking cure, if you've ever heard that phrase. I don't believe he's actually the first person that did it. He's just the first person that did a lot of writing about it and really kind of put together a real comprehensive theory in therapy. He believed our basic personality, our basic character was formed when we were very young, by age 5, and that sexuality was the main driver of our personality development. He also believed that there's a lot of aggressive impulses also that went along with that. Simplistically here, he organized the structure of the personality into 3 major components. The id, which is kind of like the internalized child part of us that seeks pleasure and only thinks of short-term pleasure and gains and doesn't want to delay gratification. Everything is about pleasure and immediate gratification. And then we have the ego, which is kind of the adult part of ourself, which manages the child and also kind of manages the superego, which the superego is kind of like it's an internalized parent. It's the part of us that tells us you should be studying, you should be paying more attention to your spouse or children. There's a lot of shoulds with superego. Superego has been compared to like a critical parent that we kind of carry. When you see young children, sometimes they to be in the world, they kind of internalize a parent a little bit, and you can actually see them repeating probably what their mom told them or dad told them. But an example is a child about to cross the street when they're first grade, second grade, that kind of age. You might hear them say to themselves, "Look both ways," and that's the superego part of them, the internalized parent that is telling them to do that, and sometimes they'll actually say it out loud. You can hear it. So the superego is the part of us that it's kind of a critical parent that is wants you to delay gratification, and you should have already done all your work. You should do this. You should do that. You should. And so the superego, when it's out of control, it can make us feel really bad. And so that's the ego's job, is to manage, get a healthy balance between these two. All right, so I have this cartoon here. It's Uncle Sam getting psychoanalytic therapy. And I include this just to show you how it's set up. The psychoanalyst or psychotherapist sits outside of the view of the patient, and mainly the patient talks, and the psychoanalytic therapist doesn't really say much. They might say things at the end to kind of interpret some meaning out of what the patient's been saying. But they do that on purpose. They want to sit outside of the patient's view, because what they're hoping for is that the patient will transfer feelings onto them from whatever relationship is causing problems in their life. And then once the patient transfers their feelings onto the therapist, then they can work through them in a better way. That's something we call transference, which we're going to talk about in more detail later on. All right, so this is how Freud saw the mind, as kind of an iceberg, where the parts of our mind that we're aware of are very, very small. The very top of the iceberg you see from this illustration, like your thoughts and your perceptions. Then you have your pre-conscious level, where it's a part of our mind that we can access if we try. We try to remember something. Somebody asks you, tell me about how it was when you were 10 years old, and you can go back in your memory and you can access that knowledge. And then you can see the huge part of the iceberg here is the unconscious level. And the unconscious is where a lot of our kind of primitive impulses live, our sexual desires that might not be things that we can accept about ourselves, or maybe some aggressive, violent impulses that we might have that we also can't accept from ourselves. Some kind of buried things that were too shameful to have in our conscious mind. So that's, and what Freud thought you really need to do in the therapeutic hour is to bring whatever those conflicts are. Well, let me rephrase that. He believed that the problems that a real distressed person was having, they were from unconscious conflicts that were unresolved. And he believed the way to work on those was to bring the unconscious conflicts into your conscious mind. And so the therapeutic techniques that we're going to talk about later on in this recording, they're all based on trying to get the unconscious conflicts into the conscious mind where you can work on it. So Freud was famous for, and this is a life cycle theory, his 5 stages of psychosexual development. And so we'll look at these 5 stages and talk about how a person might appear that's fixated at this stage. The first one is the oral stage, from birth to 18 months, and that's where babies are kind of walking around. They explore the world through their mouth. That's why you have to make sure there's nothing dangerous the baby can swallow, because they put everything in their mouth instinctually. Somebody that's considered fixated at this stage is somebody that uses their mouth a lot for either eating or smoking or talking. And so that's how a person looks fixated at the oral stage. Anal stage from 18 months to 3 years. The big the big challenge in these years is toilet training. This is the first time in our life that there's been any kind of demands made on us. There's up until toilet training, it was just totally acceptable for us when we needed to have a bowel movement to just poop our pants. Um, but now you're being told to hold it and to be able to, go to the toilet and use the toilet, which is it's like your first big accomplishment in life is a successful toilet training. Um, the way people get kind of fixated on this stage, first of all, the big challenges are control, first of all, and cleanliness. And so a person that's really over controlled and over clean and over organized, that's what we would call somebody that's that's anal retentive, a term you've probably heard before. And the other way that somebody can get fixated at this stage is somebody it's like they've tried to do this control and they've, almost everyone has successfully navigated this stage and gotten toilet trained. But there's some people that the control, they did really pick up on it, and the cleanliness part, they felt like a failure and they didn't really follow through. And so, they might generally have met the minimums. In other words, they don't go around smelling like feces, but they're very, they're not very clean, and they're very disorganized. And so this is what we call an anal expulsive person. So a person fixated at the anal stage in an expulsive way is somebody that generally doesn't take good care of their ADLs, not to the extreme, like I said, you know, they completed the toilet training. They don't smell like feces or urine, but they are just disorganized. They're, they're not going to have the best ADLs. They're not going to be somebody that takes real good care of their grooming, but they're also their house is gonna be messy, their office is messy, their car is messy. Um, they're not gonna be super clean and organized in their life. So that's fixated as an anal expulsive. Then the next stage we have is the phallic stage, and this was, in the Victorian times where, everything was kind of male dominated. So the phallus is actually the part of the penis, the shaft of the penis. And so it was the phallic stages where from age 3 to age 6, where there's kind of the child it's the first time they're really sexual. And sometimes part of the training with a kid at this age, you have to tell them not to touch themselves in front of other people. Little boys tend to want to hold their penis all the time. And so you have to be careful as a parent to not make them, you have to redirect that, but without making them really ashamed, because you don't want them to kind of have that kind of stuff going on, but teach them, not to do that kind of thing in public as well. That's a private thing. And so kids in the phallic stage, they're famous for running around naked after their bath, and not being self-conscious at all. And then when they get to be to the next stage, latency age, well, let me tell you what it looks like to be fixated at the phallic stage. Fixated at the phallic stage, one of the things about the phallic stage is you're sexual, but you're not really that relational. Your sexuality is really just about your sexuality. It's not as an interaction with another person. Although it is normal for kids at this age to do sex play with other kids, kind of exploratory sex play. And that's not something to be worried about. That's normal in the phallic stage. But um, but generally, their sexuality is just about theirs. Although they are curious about others, but it is really it's not about they're not trying to have a relationship with another kid. Then the next stage after that, latency. Latency, the word is another name for sleep. And so it's kind of thought that at age 6 to 12-year-old that your sexuality is kind of sleeping at that time. Just to go back to phallic for a second, I forgot to say how that looks fixated. So fixated at the phallic stage would be somebody that as an adult is they're just focused on their sexual conquests, or for men it would be trying to have sex with as many women as possible and not really letting themselves get into a relationship. With women, it's it's the same way, getting people, showing kind of your power. It's not really having sex with a bunch of different people. With women, it's more like getting a lot of sexual attention and getting getting men to spend money on you, those kind of things. Those are what's thought to be like phallic stage fixation for women. Yeah, so that's being fixated at the phallic stage. Those are those examples. The latency stage, like I said, it's latency is another word for sleep. So it's kind of thought that the sexuality kind of dies down and is kind of sleeping during this period as the child kind of learns how to succeed in society. They go through all the grades where you learn how to read and write and how to follow a structure in school, be part of a society. And somebody that's fixated at the latency stage would be somebody that's just very asexual, that doesn't pursue sexuality at all, either alone or with another person throughout their life. That's somebody fixated at the latency stage. The genital stage is considered basically adulthood. So this is somebody that their sexuality is in the context that, their sexuality is with themselves in terms of kind of knowing what they like and but it's expressed through their relationship with, other adults. And that's kind of, with Freud, that's kind of where it ended, where he believed that this was adult sexuality at these ages. So there's no real fixation at the genital stage because that's where you're supposed to get to. And so really just the other ones are where you kind of get stuck, where you need to evolve your development. All right, our next major theory, and probably not a ton about this in your textbook, but it's in the prologue of Love's Executioner, is the existential view of it's one of the schools of thought in psychology, and Irvin Yalom is one of the big theorists in that, in addition to being the author of your Love's Executioner book, and also he's big in group therapy, which we'll talk about, I think, in part 2 of this lecture. But just a basic with Irvin Yalom and his view of his existentialist point of view is that there's basically, for a person to be psychologically healthy, they have to accept these 4 givens of existence, and that a lot of problems with human beings are not being able to accept these four givens of existence. So number 1, the inevitability of death for each of us and those we love. He saw religion as a form of death denial, that you don't really die, you go somewhere better if you were good and somewhere bad if you were not good. He saw that as all death denial. And having to be able to understand that you're going to have to let go of all the people that you love eventually, unless you die first, but even then you have to let go of the people that you love. And then number 2, the freedom to make our lives as we will. And what he meant by that is that we don't have a predetermined destiny, that we all have have the agency, the ability to accomplish things in our life. Number three, that ultimately we're alone. There's an ultimate aloneness. Even if you're surrounded by people all the time, you're still mainly by yourself. And that people have to, part of being a healthy person is that you have to be okay with being alone sometimes. And then number four, the absence of any obvious meaning or sense to life. What he means by that is that it's not that life doesn't have any meaning. What he means by that is each person has to find their own meaning for their life. There's not some external figure that can tell you what the meaning of your life is. That's part of your job is to discover it for yourself. There's no wise man that you're going to find in a cave in the Himalayan mountains that is going to tell you what the meaning of your life is. It's not external to you. It's something that you discover within yourself. All right, our next big theory, the interpersonal theory. And this is Harry Stack Sullivan and Hildegard Peplau. And Sullivan was a psychologist in the 1950s. He came up with this theory that in our interpersonal relationships, that's kind of how we develop. And Harry Stack Sullivan, he was part of the influence of this was he was a homosexual in the 1950s, and I don't remember exactly where he grew up, but it wasn't in a place that was very open to that, and so he had a lot of isolation and was very lonely, and he saw, when he was able to have interpersonal relationships, that's what really helped him, and so that's why this kind of built into his theory. And then Hildegard Peplau, she adopted it and kind of brought it into nursing theory, psychiatric nursing theory. She was one of the first big psychiatric nursing theorists, and she has some other concepts that we're going to talk about. But she felt like your personality develops, both of them, interpersonal theory feels like your personality develops directly as a result of your relationships. And just like anything, the challenges of your relationships, the failures in your relationships, those are all the things that kind of build your personality. All right, so the relevance to nursing practice, first of all, Hildegard Peplau put a lot of thought into this, that our relationships with patients, they go through these different different forms. Um, another thing that Hildegard Peplau was famous for was the levels of anxiety. I'm not going to go into details about it here, but she's the one that said, like, you need a little anxiety before you can accomplish anything, because you need something to motivate you to work, and then moderate anxiety, you start to get less effective, and then severe anxiety and panic, you're not able to learn anymore. And so more about Hildegard Peplau. She saw these roles that you'll be in as a nurse, and they're all kind of loosely related. You start out as a stranger, like you do in all of your relationships, and then go through all of these. So we have Eric Erikson. Eric Erikson was a psychologist. He came up with this theory. It was actually just a small chapter in a book he wrote, and it turned out to be kind of a new idea, a different way to look at the development of a person. And so this is what made him famous. He was actually more interested in, he would write these psychological biographies of famous figures like Abraham Lincoln, but this is what made him the most famous and why you probably have heard of him, because sometimes we have the Erickson stage as what you have to identify in a nursing paper. So these are the 8 stages, and a lot of these they people kind of predictably go through these stages, but you can work on 2 things at the same time. They're not mutually exclusive, but generally this is the pattern it takes for people. I'm not going to spend a ton of time on this, but it is something that you'll want to know, you know, before you take the NCLEX especially. All right, individual psychotherapy, um, as it says, individual, it's just you and the therapist. It can be any of a number of different professions, and these are some general terms here, but it can be focused on certain things, or it can be just focused on interpersonal problems. One of the things about a therapeutic relationship is it is a relationship, and so if you have relationship problems in general, you can seek to work them out through your relationship with your therapist. Psychoanalysis is a form of individual psychotherapy. It's also called psychodynamic psychotherapy, and generally psychoanalytic therapists, if they really go strictly by the theory, they meet with you multiple times a week. It can be very expensive, and so it's considered kind of a rich person type of therapy. But it also is focused more on the kind of intrapsychic things that are going on deep in your mind versus the way the symptoms are looking in your current life. So techniques psychoanalytic therapists do, or psychoanalysts is what they call them. So techniques to try to make your things going on in your unconscious mind, to try to bring them into your conscious mind so that they can be worked on. These are the techniques. So free association, what that means is the therapist is there and you just kind of say whatever comes up to on your mind, comes to your mind, and just say it without thinking about it or analyzing it. Just say it. Analyzing your dreams, going under hypnosis and trying to go back to certain memories. Catharsis, which just means getting out your emotions, kind of yelling and screaming sometimes. Word association, where the therapist says a certain word and then you say whatever word comes to your mind in response to that word automatically without thinking about it. Then we have the things in the relationship that I referred to earlier, the transference, where with transference, it's a phenomenon that is natural that, when we encounter somebody that we don't know, it's natural to transfer feelings and expectations from a previous relationship that person might remind you of. So that's a natural thing that happens in all of our relationships, therapeutic or not. Um, in psychoanalysis, they use that tendency to on purpose and try to encourage it, because they're trying to get you to transfer feelings onto them from whatever important person in your life, usually an authority figure, usually one of your parents, that your conflict is about, that's in your unconscious, and to bring out whatever that conflict is into your consciousness, and that way you can work it out with the therapist. And then the countertransference is the therapist's feelings about you. And so, that comes out in the therapy, where sometimes the psychoanalyst will tell you what feelings that they had about you, and then you evaluate, why that could be. Um, it's basically whatever the therapist projects onto you. Okay, so just some basic, it's about interpersonal psychotherapy, just kind of regular non-psychoanalytic therapy. It's generally time limited, especially if you're having it paid for by your insurance. They'll generally just you'll get a certain amount of sessions per year, and then their managed care department has to approve every couple of them. Um, and so it is time limited if you're using your insurance. If you're just going to a therapist, you're paying out of pocket. Sometimes that can go on longer as long as you feel it's being helpful. And then for the interpersonal therapy, your focus is on your relationship with the therapist and your current relation, how it's going in your personal relationships. So an interpersonal psychotherapist in the tradition of Sullivan and Peplau, they, an example is if they want to know how you're doing in your relationships, they'll ask you, certain questions about, tell me about your relationship with friends, something like that. They're going to ask you about your relationships. And, that's where their focus is going to be. All right, so we have cognitive therapy. And cognitive therapy, the word cognitive means thought. And so that's one way to remember what cognitive therapy focuses on. It focuses on your thoughts. And, all of us, when things happen to us, things don't just automatically make us feel a certain way. Things happen and then we perceive them, and that, the results of our perceptions are really what makes us feel a certain way. And so cognitive therapy, you teach the patient to evaluate their automatic thoughts or automatic perceptions of things that occur. And so it's been affected with depression, with anxiety, and what it tries to do, it doesn't focus on anything in the unconscious mind. It's all about symptom relief, getting, feeling better now. If you can analyze your thoughts and change the negative patterns, the negative way that you perceive things, you're generally going to feel better faster. And so they have different ways of trying to help you do that. There's going to be something we're going to talk about in a few minutes called a mood log or an automatic thought record, where you're writing down in columns, and also just focusing on how you're interpreting what happens to you. Okay, so automatic thoughts, those are what automatically happens to you. There's some people, something great could happen to them, but they're in such a habit of interpreting everything negatively, they still would feel negative about it. Kind of an extreme example are, when somebody wins the lottery and the first thing they think about is they're going to have to pay all those taxes, and there's all these charities that are going to contact them, and then they won't know if people want to marry them for them or because they want their money, all that kind of thing. Those are automatic thoughts that are usually negative about things. Some of the types are personalizing, where everything is personal. Somebody, you're supposed to have lunch with somebody and they cancel on you, and you assume it's because they really didn't want to have lunch with you, when it actually could be true that the reason they told you they had to cancel was a valid reason. All or nothing thinking, where you think people either totally are on your side or totally against you. Everything is always really good or really bad, with a tendency to see things as bad. Mind reading, assuming that other people have negative perceptions of you without checking with them and just assuming that things are negative. And then discounting positives and seeing everything as a negative. So anytime that an example, somebody gives you a compliment, you've probably known somebody that anytime you give them a compliment, they kind of insult your compliment and don't accept it. Um, Not able to see anything positive about themselves, and they may have been trained that this is some cultures you're seen as not being humble if you don't initially argue with a compliment, but these people kind of really believe that that the compliment is really not true. All right, so this is a mood log, also known as an automatic thought record. And if you look at it, so this is something a patient fills out. And if you're going to do this with patients, you should actually do this yourself. It's not easy. And one of the things about cognitive therapy, when you're going to use a mood log like this, you don't want to use it with somebody that's severely depressed because they're not going to have the energy to do this kind of thing. You can see it's a lot of work. Our severely depressed people, if you give them an assignment like this, it really just gives them another thing to fail at. So what you want to do is give these kind of assignments when people are feeling better and they're looking at trying to keep feeling better and work through things. Mostly, a lot of our partial hospital programs use cognitive therapy and use these kind of techniques because the patients are stabilized. As you can see, this thought record. So there's a date and then the situation. This person, they're laying in bed trying to fall asleep. It's after 1 a.m. I'm waiting for my second round of sleeping pill to kick in so I can go back to sleep. Rob just told me that Jeff and Liz are expecting a baby. And then the person rates their emotions on a scale of 1 to 10. And so she says she's feeling sad. And on the scale of 1 to 10, the intensity is about a 6. And so her automatic thought about this situation is everyone around me is pregnant. I'm starting to feel left out. My children are always talking about the baby that's going to come to our family, and it makes me sad. And the intensity of that sadness is a 9 when she thinks of the automatic thought. And then this is the key. This is where we're trying to, the next category called the rational response. This is where we're asking the patient to create another way to think about it. They might not believe it right now, but what is an alternative way that you could have thought about this situation? And so you can see there's some effort there. The person has to be not so severely depressed that they can see it, that they can do it, that they can see that there could be a possible rational response that's not the one that they're currently having. And so her rational response that she comes up with here is having another child is still an option. You need to take care of yourself right now and the children you already have. Think of all the sweet babies you're going to be able to get to hold and love and then give back to their parents. No sleepless nights, poopy diapers, baby puke, bottles, breastfeeding. And then how does she feel after considering this alternative to her automatic thought, the rational response? How does she feel now? It says, okay, I feel better. And then a 4, and then I mean, even though feeling better, it's not really an emotion, but you don't worry about that kind of thing. And then she feels at peace, a 6 out of 10. So that's kind of this person is doing well with the automatic thought record. It worked. And it's a way of kind of training yourself to not automatically see things in a certain negative way by looking at a possible alternative way that you could interpret it. And so it looks like my guess is it's probably real. It's very realistic about how these things look. And so So yeah, so that's cognitive therapy. All right, thank you. This has been Introduction to Psychiatric Nursing Part 1.